Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to continue talking about first rib syndrome. Now, in the previous video, we discussed, first of all, what is first rib syndrome and how to assess for it. So if you need more information on that, go back and take a look at that video. We're going to begin talking about the treatment of first rib syndrome, more specifically on exercises that you can prescribe, or if you're the one with the condition, that you can do to help get your first rib moving better. In the next video, we're going to be discussing manual therapy techniques to help get the first rib moving better. But before we get to the exercises, let's do a very brief review of some of the key points that we talked about in the previous video. Now, I'm going to be focusing pretty much entirely on the left side of this picture right here. If you look where my mouse is, that is the manubrium of the sternum. And on the left and the right, there are two important structures that attach to it. On the top here, superiorly, this is the right clavicle. This would be the sternal end of the clavicle, and you can see the clavicle coursing around over to its acromial end over here, where it attaches on the acromion of the scapula. Now, the inferior structure that attaches on the manubrium is the first rib. This is the right first rib, and this gray component right here, this would be the costal component of the first rib, this cartilage by which it attaches on the manubrium of the sternum. Now, we don't get to see too much of the right first rib right here, but what we do see is anteriorly, it courses underneath, inferior to the clavicle. If you're trying to touch the first rib, whether it's through banded mobilizations or manual mobilizations, anteriorly is not going to be the way you're going to attack it. Okay, it's covered up too much by this clavicle, and we're not going to get the component that's usually stiff in first rib syndrome. Okay, what we do see here, though, is as it courses underneath the clavicle, there's a space between the two. On top, you have the clavicle. On the bottom, you have the first rib. That space there, which it's trying to show with this circular dotted line, that is the costoclavicular space. And through that space, we have the subclavian vein, we got the subclavian artery, and we've also got the brachial plexus, all these nerves that are running out from the neck all the way down into that particular upper extremity. And what we don't see here is the posterior part of the first rib. It's covered up by all these structures, but essentially if you traced my mouse like this, it would go all the way over here and attach on the T1 vertebra. The posterior scalene right here attaches on the second rib, but the anterior and middle scalenes, these attach on the first rib. Okay, so what you could see here is that if the first rib was elevated, that costoclavicular space is going to be diminished, and you get potential impingement on these structures that course through the costoclavicular space, i.e. the nerves. Now, remember that first rib syndrome can manifest in a couple of ways. Number one, you can have a situation where there are no radicular symptoms. So let's say I'm talking about my left first rib. There's no numbness, there's no tingling, there's no pins and needles, no shooting pain, no nothing down that particular upper extremity. There's simply isolated pain at or around the first rib. And remember, whenever you have pain associated with the first rib, it's generally because there's hypomobility or stiffness at the costotransverse joint where the first rib articulates with the T1 vertebra. Okay? The other way it manifests is with radicular symptoms. So you could have a combination of numbness, tingling, pins and needles, shooting pain down the arm that looks very similar to a cervical radiculopathy. But remember, in a cervical radiculopathy, not only is the impingement site different, in that case it's the neck, but in the case of a cervical radic, you would have more a dermatomal pattern of those radiating symptoms, whereas in a first rib type of situation where that's impinging the nerves, you would have a peripheral nerve entrapment pattern. But remember that the radicular kind of first rib syndrome can be associated with first rib pain, but sometimes it's not associated with first rib pain. Some people are completely unaware that this first rib is affected. So, in either case, non-radicular, radicular, we want to get the first rib moving better. So, on to the exercises. Now, manual mobilizations and manipulations on the first rib are a great way to get the first rib moving better, but the obvious downside to those is you have to have someone who's able to do them. Or when the person goes home, what are they to do for their reinforcing exercises? Well, that's where these banded mobilizations with movement come in handy. And these are techniques that almost anyone is going to be able to do at home. And you do need a thick resistance band like this. Sometimes we call them monster bands, pull-up bands. The typical TheraBand, those thin ones that are used in clinics and often offered to patients, those are great for a lot of things, but those do not apply enough resistance to really be that effective for mobilizing the first rib. So if you're going to use a band, it's got to be one of these, and I'm going to put a link to purchase these from Amazon in the comments of this video, so keep an eye out for that. So first things first is the setup. Let's suppose I'm trying to mobilize my left first rib. So what I'm going to do is I'm going to, first of all, move my right arm through this, put it over my head so it goes right over my left first rib. And I'm essentially wearing it like that ammunition satchel that Chewbacca wears in Star Wars, right? It's pointing from my left first rib all the way down to my right hip, or my right ASIS if we're getting really technical. Then what I'm going to do is I'm going to take my opposite leg, cross it up, put this under the right foot. That will hold it down on the ground, and now we're getting this band exerting a force downward and a little bit medial on the first rib. And in fact, if I was doing a manual mobilization, which we'll talk about in the next video, I would actually be doing an inferomedial mobilization. It's not just inferior, it's inferomedial. So it'd be about 75-80% inferior, about 20-25% medial. So this is the exact angle of pull that I want here. Now, in this position, there are usually 3 techniques that I have any given patient do. The first one is I'm going to perform diaphragmatic pursed lip breathing. Inhale through my nose deeply, exhale like I'm blowing out a candle deeply. The reason I do this is because the scalene muscles, particularly anterior and middle scalene, they insert on the first rib. So we want the first rib to be mobilized inferiorly. When we inhale with some degree of force, the scalenes contract and they try to pull that first rib up superiorly, but the band is essentially blocking that. So we're getting an indirect mobilization, or you can think about it as sort of a muscle energy technique. So what does it look like? It looks like this. Inhale through the nose. Exhale like you're blowing out a candle. If you feel like this is not providing enough force, you can either get a thicker, heavier band or add a little bit of downward pull on it. And with this technique, normally I will set a timer for 2 minutes and have the patient just do this inhale, exhale, no rush, but slow, deep breathing for 2 solid minutes. Now, what's very important to understand here is that the first rib doesn't just move when we're breathing in and out, inspiration, expiration. It also moves as the shoulder moves. So generally speaking, as the shoulders come up above the body into elevation, the first rib is going to move up, and as the shoulders come back down, the first rib is going to depress back into its starting position. Also, as my neck moves, the first rib is also going to have to move. So whether I'm rotating, side bending, flexing, extending, and whatever it is, the first rib is also going to make small movements in accordance with the neck. So we can use both of those things to our advantage when we're trying to get the first rib moving better. So the first case we're going to look at is using shoulder elevation to get the first rib moving better. So here I am in the exact same position that I was for the diaphragmatic pursed lip breathing mobilization. What I'm going to do is take that same arm and just lift it up in a controlled fashion through a pain-free range, and then bring it back down. There really isn't so much of a hold that I use on this. It's more of like a flow, just up and down, up and down. And you might be asking, am I using flexion, scaption, abduction of the shoulder? In most cases, it doesn't matter. If the shoulder motion doesn't really cause any rib pain, then it doesn't really matter what motion we use. Any way you put this, it's going to get the first rib moving better. Now, one question you might have is, when I lift the arm up overhead, am I using flexion, scaption? Am I using abduction of the shoulder? Well, if you have a particular patient where the shoulder motions don't aggravate the first rib, or they don't aggravate the radicular symptoms if those are present, then it doesn't really matter which shoulder motion you do. The arm is going up overhead, so the first rib is going to receive a good mobilization. In that case, I would pick just whichever motion is most comfortable on the patient, and for most cases, scaption is going to be the best option. Now, if you do have a patient where shoulder motion is provocative to the first rib or it's provocative to the radicular symptoms, then you pick the shoulder motion that reproduces that, and you just do it through a range that doesn't trigger those symptoms. So let's say in one situation it's abduction, okay? Maybe right around there during the mobilization, it starts to reproduce symptoms. So what I would educate the patient on is stay just short of that and do the motion like this. And what you might find is as they do this, whether it's in the same set or as the week goes on, they're doing this every day, you might be able to go a little higher before that onset of symptoms comes on, until gradually they should be able to go all the way up to the top. And that could happen within one treatment session. It could take a while for it to take effect. But that's how you go about deciding which shoulder motion to perform. And then finally, we have our third banded mobilization with movement, and that is head or neck movement. Now, with the neck, I usually do one of two movements, either rotation or side bending. A lot of people are going to have pretty big limitations in side bending. Usually, as people get older and they're sedentary and all these muscles tighten up right here, side bending becomes the most limited the most quickly. So if they don't have much side bending to work with, or side bending is just painful on the neck, which is the most likely to be for most people, I'm going to choose rotation as the movement. But either one of these work pretty equally well in my experience. Again, like with the shoulder, if you have a particular motion that is painful at a particular point, you want to educate the patient to stay out of that range initially. So for example, if I'm doing this mobilization, and let's say we rotate, maybe right here, it triggers pain, I might cue them to stop a little short of that. And again, as we're doing, let's say this rotation mobilization, you might find that over time they're able to go a little bit further before that onset of pain of the first rib or radicular symptoms down the arm. You play this game the same way for any way you do these mobilizations. And over time, if this is in fact the issue, the first rib will get moving better, which means the pain will be reduced, and in all likelihood, the radicular symptoms will reduce as well. You might find they start to centralize, or in some cases, they disappear altogether. And in my experience, if you get a spot-on diagnosis of this and you treat it effectively, most people will respond very quickly to this type of treatment. And the nice thing about the banded mobilizations versus manual techniques is the person can grade the resistance and the mobility that they're using, whether it's of the shoulder, the neck, or whatnot. They can grade it themselves, so that way they're not being pushed through too much pain. But make sure that you educate the person that we don't want to push through the pain. We want to either just touch it and come out of it, or just stop just short of it. And over time, that pain-free range will increase until eventually the condition is gone. Just like magic, except it's not magic. So hopefully this video gave you a good understanding about how to yourself get the first rib moving better. In the next video, we're going to be looking at some manual techniques that accomplish the same thing. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.